Today, I'd like to go through a case I found particularly interesting, and it was one of those almost miracle cases where you're not really sure, how much you can help this person, and it turns out to go even better than you expect, and it goes almost exactly how you would plan it, and someone recovers 100%. And so I think this is a good example case for someone, particularly if someone's been diagnosed with a peripheral neuropathy or something to do with sort of post-surgical pain. So in this case, I forget her exact age, 50s, 60s. A woman had a double knee replacement, one knee replacement, then the second knee replacement. And so she had pain at sort of around both knees, one worse than the other. And she also was diagnosed with peripheral neuropathy. She couldn't really feel her feet very well. And of course, she had pain from about, just on top of the knee to all the way into her feet. And as I said, lack of sensation. She also complained of muscle spasms as well, and the muscles being tight, feeling tight. But yeah, that complaint of not being able to feel the bottom of her foot, like she was wearing like 2, 3 layers of socks, and just that lack of sensation with the floor. It's not a comfortable sensation where you can't feel the ground. So she has this pain and lack of sensation, and she said she visited one neurologist, gave up, went to another neurologist, also gave up. So both neurologists just she said they're at the end of the rope. I was like, I'm just started. I'm at the beginning of the rope. I'm not sure if that works with that idiom, but yeah, I'm just getting started. And of course, the first thing I did was, well, peripheral neuropathy, both legs. I think, oh my goodness, this might be something systemic. For example, diabetes. Diabetes can result in peripheral neuropathy, tends to start in the feet. Vitamin B12, alcohol, B12 deficiency, or someone who's an alcoholic, they can also get peripheral neuropathies. And peripheral neuropathies tend to start in the feet, or often start in the feet. So I was like, well, let's look at your blood work, and blood work, and actually drugs. Drugs can cause peripheral neuropathy. We looked at her drugs, and nothing really jumped out at us. And I was like, okay, so for the moment, we're going to assume that it's neuromusculoskeletal, like it's something more structural, or has to do with the nervous system, and it's not a drug, or it's not a deficiency of some sort, or it's not a disease of some sort that has to do with the whole body. It's more structural or connected with the nervous system and the brain. And we're going to work with that assumption. And I told her, if we only get you 50% better, then maybe we need to or if we don't get anywhere, maybe we need to revisit some of these drugs and revisit the blood work. So we started with that, and we had that discussion, and now, okay, let's tackle things. And I started with, well, knee replacements, right? And I asked her, well, have you had someone work out the scar tissue? She's like, what? Now I laugh because it's an obvious thing to me. And it does happen in some PT rehab places. The physiotherapist will break up scar tissue, but I've now talked to so many people with chronic pain that the physiotherapist doesn't break up scar tissue, or doesn't help break up scar tissue. So scar tissue, you can have sort of skin being attached to muscles, and muscles being attached to other muscles, and the muscle fibers sort of healing in a way that they're all bundled instead of, in parallel lines. And that's no good. Now, luckily, scar tissue is weaker than healthy tissue. So if you go in there vigorously you're basically trying to break up the scar tissue, you're more likely to break the weaker, disorganized tissue, and the parallel fibers, the healthy tissue, is more likely to survive. This can be painful. It is painful, not can be. Breaking up scar tissue is painful, but has to be done. And women in general have a much higher pain tolerance than men. But even her, she was like gripping the chair, and all I was doing was working out the scar tissue. I started even very gently. Now, the knee she had the most pain on had this raised zigzag, and I was like, what the heck happened here? And it's almost like the muscle had, when it healed, and so they must have cut through the muscle. Um, when it healed, it almost healed, and then some of the fibers, it feels like it's pulled up the muscle and almost did this curl at where the muscle rehealed. And it's like, so let's fold this back down. So typically when I break down scar tissue, it's these thrusts and it's vigorous. This was just me just sort of pushing it this way and then sort of wiggling it and wiggling it side to side, wiggling it. And within 1 to 2 sessions, instead of this big bump and that you could see through her leggings, you could see, those tight pants, whatever they are, you could see this zigzag bump and flat, and pain way down, way down. Now that took a couple sessions because it was so intense and it's such a long scar. Now the skin was also caught on the muscles underneath, so I had to grab the skin and pull and push the skin around. Now when I checked the other knee, there doesn't seem to be anything wrong with that one. So I suspected. Now this can be, if you have a lot of pain on one side of the body, you can sometimes start to feel it on the other side. So I suspected on that first visit, I sort of checked everything. I'm like, let's just work on the painful one. Let's see what happens with the less painful one. Let's see if that pain just goes away on its own. And sure enough, I only treated the right, and the pain in the left knee went away. Now, is that because it was purely neurological? That the brain was like, oh, well, the right knee's fine, and he told me the left knee is also fine, so I'm going to stop creating pain. And the brain can do that. The pain is a protection mechanism. Your brain can create pain to protect you. If someone shows you a whole bunch of x-rays and MRIs and be like, oh, if you move your shoulder, you're going to be grinding the bones, you're going to cause damage, or something's going to tear, well, then you'll start to, oh yeah, I can feel exactly what he's talking about. Oh, that hurts. Oh yeah. Well, the brain heard that. I was like, oh, moving equals damage, or something might damage. Oh, I'll make sure moving is painful to keep you from moving. So it could be purely neurological. Now, the other thing it could be is once you get rid of pain, you might be moving more naturally. She might be putting more weight on that right knee, which takes weight off of the left knee. So it could have been something like that. I've had other cases where ultrasound is actually, a musculoskeletal ultrasound is actually a great way to evaluate the cartilage in the knee to sort of stage osteoarthritis or age-related bony changes. Osteoarthritis is not necessarily painful, and I would argue in most cases it isn't, and there's a correlation with pain, not necessarily causative. And anyway, so you can evaluate osteoarthritis or bony changes, and probably the worst case of osteoarthritis I ever saw, she actually left my office pain-free because it was just some scar tissue. And I worked out the scar tissue, and that particular patient walked. So anyway, in this person, in our initial case study, pain in both knees, only treated one knee, worked out the scar tissue, pain way down. Great. But scar tissue, at least on its own, has nothing to do with peripheral neuropathy. So what I did is actually in her case, I checked sort of the common places that nerves get caught up, and I started to sort of try pull and push on the nerves and push and pull on the structures. And there's a test called Tinel's test where you tap on where the nerve should be. And a healthy nerve normally isn't that sensitive. And then a nerve that's irritated or compressed will be very sensitive. And what's great about it is you'll tap that and it'll recreate the shooting pain that they'll feel, or the pain pattern that they feel. And sure enough, I was tapping around some of the nerves and it was recreating some of her symptoms, but not all of them. So in fact, I had to say, you know what, two neurologists gave up on you. So like, you're a special case. I'm going to have to put extra effort here. And I pulled out a whole bunch of anatomy pictures and all the innervation images and the likely path of each nerve branch. And I followed every single one. And sure enough, it was like 3 or 4. And it was slightly different ones on different legs. And yeah, and I had to work out and the path of all the nerve. And sure enough, sometimes there were angry muscles and there were muscle knots. And sure enough, there were fascial adhesions. And I tried to break those down. Now, I don't do injections, but if you do find sort of where a nerve is sort of caught up in the tissue, they can do something called a hydrodissection, where they can use a little bit of cortisone, maybe a little bit of an anesthetic, and they basically surround the nerve with fluid and try to just push all the tissue away from it. They can also use the little bit of the needle to sort of cut some of the tissue, sort of grabbing on to the nerve. Of course, me just pushing and pulling, I think, can achieve the same goal. I'll mention that cortisone is very damaging to collagen, which is why it is great for sort of that purpose. And I will caution a lot of doctors do use cortisone for tendon pathologies, and it actually weakens tendons which are made of collagen. So if a doctor's like, okay, let's just give you a cortisone shot, be like, okay, what's the pros and cons of this? What's my diagnosis? I think you have tendonitis. Wait a second. So I know I'm off on a tangent now, but it's, risk versus reward. I think often patients don't make an informed choice when it comes to cortisone. Anyway, back to main topic. So I'm not using hydrodissection to loosen up the nerves. I'm just pushing and pulling. I'm poking and prodding muscles to free up space on the nerve. I'm pulling, using the joint to try to pull the nerve back and forth. A lot of these skin nerves are superficial, so it's pushing, pulling on the skin, freeing up fascial adhesions, just trying to make sure the nerve isn't caught up anywhere. And sure enough, after doing that for a couple sessions of push prod, finding like we're like consulting, my textbooks. Okay, where's that more likely to go? Let's follow it right to the end. And we got about was it like 50% better in one foot and 40% better in the other. There's a common irritation point where the fibula meets the tibia near the knee, and there's a joint there. And so that one, I worked out that on both. That tended to be a point for both legs. And so she had no nerve symptoms near the knee or in the calf anymore, and in either one. But she still had some of that lack of sensation. She said she was like wearing ankle socks. So still a lack of sensation, but they were thinner socks, and it was just sort of ankle down. And again, it was better. It was better. No pain, just lack of sensation. And I checked both again. Really checking all those. There's no, everything. And I was like, you know what? I think your brain forgot. I think your brain forgot. I think, and she didn't really describe it as a lack of sensation anymore. She said it was sort of webby. Was the word she used for it, which is still a lack of sensation. But not as much as those 3 layers of socks. So it was an improvement, but yeah, this webby. And I thought, what? The brain forgot. The nerves are fine, the sensors are fine, but the brain forgot what to do with the information, or how to access the information, how to put the information together. Now I went to her, I was like, okay, this is going to sound crazy, but I think, I told her that the brain just forgot how to access those sensors and how to use those nerves. I don't know if that will make you from 50% better to 80% better, or maybe just 60% better. I don't know if this will get all the way to 100%, because normally when I go to brain, they're already like 80% better, and the brain does that little last 20%. But is someone who wakes up from a coma, they have to relearn to walk. Now it's not just the muscles being weak, but the brain has forgotten how to walk. So maybe her brain has forgotten how to access that sensation. And sure enough, when we were done, she was just better, and it was like 4 sessions. But we needed to relearn the sensation. So I took a metal pinwheel of pins for pain, and we did things like I did on her arm. This is what it feels like. Ouch, ouch. Okay, yes, Brandon, I know that hurts. Ouch. Okay, so you're thinking about that. Now watch, stare as I poke your foot. And sure enough, ouch. So we did ouch everywhere, back to arm, back to foot, back to arm, back to foot, so she could reprogram the sensation. We had her using her toes, and again watching me move her toes, watching she was watching me. We had a mirror so she could see the bottom of her foot, watching me poke in different places. We had her we had sort of this textured rubber surface, and so she could see the pattern and she could try to feel the pattern with the bottom of her foot. We also tried to have her move different toes individually, try to get those muscles working, because part of our sensation for where our foot is in space is from the sensors connected to joints and to muscles. You know, how far a muscle is stretched lets you know how far that sort of joint has moved, which gives you a feel for what's going on. So it was after one of these sessions that she said, "Brandon, my muscles relaxed." Because if you remember, one of her complaints was, her muscles felt tight in her calves, which sort of makes sense. If you can't feel the ground, then maybe your calf muscles are going to stay tight, just in case you have to support yourself, because it doesn't know what your foot is doing, what the ankle is doing, where the ground is. So the muscles in her calf, I guess, were just always tight, 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 tight. And when she could feel the ground, she started walking. She said, "They're I they haven't felt like this in years. They're relaxed, like all the tension." In fact, she didn't just say her calf; she said that the tension in her whole leg, so it even affect her hips. The tension is just gone. So we got her full sensation back again, tension in her whole leg and hip gone, all the pain at the knee gone. So 100% success story there. Now, I did continue to see her for another issue, but her initial complaint solved. And just to give you an idea, now with the legs, I mentioned if it didn't improve, I would have gone to check out drugs and things like that, drug systemic diseases, also back, L5S1, radiculopathy, nerve roots as they're leaving the spinal canal, spinal cord. So think of other things that can cause nerve symptoms in the legs. So I would have gone down that path if what I didn't result in her getting better. One of the things about solving someone's chronic pain is you keep on trying and keep on looking for ways to improve it. And you don't put up with someone just plateauing and being like, that's good enough. Like, well, what else could it be? What else could it be? Where can we what else can we what avenue can we pursue to get better and better and better and better? Our bodies have such a capacity for improvement. Obviously, there are limitations. For example, I have age-related bony changes in my neck, osteoarthritis in my neck. Do I have pain? No, I don't have pain. But you know what? I have little bony spikes on the corners. So if I do this, I'm a little bit more limited and I can feel pinching maybe a little bit sharper than someone who doesn't have those bony spikes at the edge. And for people with really big spikes, they might have a bony end where those bones touch together. So there are limitations with H, I suppose. But just because those bones are touching together doesn't necessarily mean that, that will mean, I'm limited in movement. If it's extreme surgery, shave down those bony spikes. But that doesn't necessarily mean that I have to have pain, right? That's just slightly limited motion because bone-on-bone contact. That doesn't necessarily mean pain. So we have such a high capacity for healing, for becoming pain-free, and having good neck muscle control and having a strong, confident neck. I think I've talked about it on these videos before. I had, I think, 15 years of on and off really bad neck pain that I don't have anymore. And it was from I had seen physiotherapists, orthopedic surgeons, chiropractors, and it was only basically doing a whiplash protocol where I was relearning how to move the neck, and using some muscles that had atrophied, that my neck pain had gone away for good. So even though I had osteoarthritis, and some of the doctors were like, you have osteoarthritis, that's the pain. You're going to have it forever. Here's your pain medication. Good luck with that. Right? I didn't give up. And that wasn't the answer. The answer wasn't just, it's only going to get worse. it got a heck of a lot better. So I hopefully this is an uplifting and positive story, and it gives you some ideas of avenues to pursue if you yourself are suffering with a peripheral neuropathy, maybe a post-operative peripheral neuropathy like this case study. Anyway, cheers. Have a good day.